Hi folks, Professor Gulliford here. Let's go ahead and do a screen share. Where's my share button? There it is. And we will find our PowerPoint on pulmonary function testing and fill you in on everything you need to know about PFTs. There's quite a bit. This picture right here is the key. If you know this spirogram, as it's called, you will be in good shape for pulmonary functions. Um, Starts with the tidal volume. That's the small volume that we all breathe in and out. Then we've got the expiratory reserve volume. And then the patient comes back up to tidal volume and then breathes in as deep as they can and exhales back to tidal volume. So that gives you four volumes and they add up to four different capacities. When I went and took your test so that I would be better prepared to teach you, I discovered on my test, the question I was asked was the functional residual capacity, the one down here at the bottom. It is ERV plus RV. And what they had on the boards were every volume was numbered, and you just had to choose which two numbers add up to functional residual capacity, the FRC. And that, of course, is ERV and RV. I hope you have that question because that one you definitely know, but it could be any combination here, and we're going to go over all of them. So there we go. Lung capacities, the four lung capacities are total lung capacity, inspiratory capacity, expiratory capacity, and functional residual capacity. Taking them one at a time. TLC is all of them. So that's actually a pretty easy one to remember. It's all four volumes added up. Tidal volume, IRV, ERV, and residual volume all added up. It's about 6 liters in males and a little over 4 in females. That male-female difference, I get asked that question from time to time. It largely has to do with the width of the thorax. If you will just look at your male friends, brothers, whatever it might be, their chest is wider and probably a little thicker also than a female the same height. So for the same height, you get about 15-20% more lung volume for males. And, there's nothing at all to do about that, but we have to take it into account because if we didn't, then it would look like every female patient we see had a restrictive defect, and that's not the case. So we know what normal is from doing hundreds of thousands of tests. We know what normal is for males and females of every height. So there we go. Inspiratory capacity is tidal volume plus IRV. And normally in males, it's about 3,600, females about 2,400. So that's the breathe in capacity all the way in. The breathe out capacity is the residual volume plus the ERV. That's called FRC, functional residual capacity. And that is the one that I had on my own test. Maybe you'll have it too. FRC is RV plus ERV. And if you take tidal volume, IRV, and ERV, that makes vital capacity. That's a big one for you guys because every time we do a spirometry test in pulmonary function testing, which is, every day, it is the vital capacity that we measure. What we do is we have the patient take their deepest breath in and then blow it out as hard and fast as they can. My patient instructions are, okay, sir, we want you to take your deepest breath in and then blast it out just as hard and fast as you can and keep going until I tell you you can stop. So then deep breath in, all the way in, blast it out, blow it out, squeeze, 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 keep going, keep going, keep going, keep going. Now deep breath in. When the patient feels like their lungs are empty, they're not. We can still see the graph moving down, so we know that there's still air that we have to get out of the patient's lungs. So sometimes the patient looks at you as though you're crazy because they feel like their lungs are empty, but they've just never blown out that far or that hard before. So you really have to coach in order to get this done well. Yeah. All right, slow vital capacity and forced vital capacity. We often do both in the course of a complete pulmonary function test. The slow vital capacity is just what I described, but it's done without forcing it out. It's just done slowly at the patient's own pace all the way in and then easily all the way out. Sometimes there's a pretty significant difference between the two. So the slow vital capacity may be bigger because if the patient forces it out, they may have some bronchospasm that shows up, and they have a smaller forced vital capacity than the slow vital capacity. So it is, an interesting comparison to make. So summarizing the lung volumes, tidal volume, that's your regular breathing volume every respiratory cycle, about 4 or 500. IRV, the maximum volume the patient can inhale. ERV, the maximum volume the patient can exhale. And then residual volume is the trapped air remaining after the exhalation. There's always some trapped air. Now, here's an interesting thing for you to figure out. In a normal patient, that's just 1,000, 1,200, something like that. But in an emphysema patient, that might be 2,000, 3,000 or more because they have so much trapped air from the damage to their lung tissue. So the residual volume tells us a lot about the patient who may have emphysema. Okay, minute volume. This is how much we breathe every minute. Let's say the patient's breathing 12 times a minute, tidal volume 450. You just multiply and you get 5,400. But now let's say they're exercising, jogging, this one says, and now they're breathing 18 times a minute, tidal volume 600. So you do the math and it's 10 liters, 10.8 liters. So there you go. Minute volume is just how much they're breathing every minute. There's a test called multiple maximum voluntary ventilation. We don't really do this very much anymore. But what we would do is we'd have the patient breathe as hard and fast as they could for 12 to 15 seconds. We just were interested in how much air they could move in and out of their lungs for a period of time. And then we would multiply by either 5 if it was 12 seconds or 4 if it was 15 seconds. But let me tell you why we quit doing that test. Now, I don't know about your hospital there. Maybe you'll still do it. But the reason we stopped doing it at most hospitals is the patient would pass out from hyperventilating. I'm not kidding. They'd fall off the chair, and we actually had some injuries. So not worth it. It's not that important. We just stopped doing it. Uh, but some hospitals still do it. Yeah. If you're going to do it, I would suggest having an assistant, another therapist or an aide or someone who can just kind of support the patient so they don't fall off the chair. PFTs, a very diagnostic tool. We rely on the PFTs to tell us what's wrong with the patient and are they getting better or worse. They also tell us, is our therapy working? So they're really important tests. And here is a young man showing us what the PFT looks like. The only difference I would have is I would have a nose clip on the young man. Uh, Most of us use nose clips because we don't want any leak through the nose while the patient's doing the test. The machine's called a spirometer. Spirometer. Yeah. I would suggest a nose clip there. Spirometry is the most common test. And the main things we get out of spirometry are the forced vital capacity, the FEV1, which is how much the patient can exhale in the first second, and then the ratio of the FEV1 to the FVC. So those are, key measures that we get from spirometry. There was a board question. I had this board question. It said, which of the following volumes cannot be measured by spirometry? And the answer was the residual volume. So you might have a question, something like that one, because the residual volume is still there, still in the patient's lungs when the spirometry is done. Okay, we get a volume time curve, and we can also get a flow volume loop. And actually, today we're relying more on that flow volume loop than we are the volume time curve. I'm sure we're going to show you some examples. There's a flow volume loop right there. That loop which, let's see, Dr. Tom Petty, not of the Heartbreakers, but Dr. Tom Petty at the University of Denver, describes this as a broad mountain, a broad mountain. That's the shape that it should be. Yeah. Now, if the patient has an obstruction, we get a scoop in that broad mountain. And if they have restriction, the mountain goes pretty much straight up and straight down. We call that the witch's hat, kind of like the Halloween witch's hat that you would see on a costume, you know. So that's the flow volume loop, and that's pretty much what you're going to need for your board exams and for this course. Flow volume loop has taken over. It's better, tells us more than the volume time curve. So there we go, flow volume curve or flow volume loop. Um, we can get a peak flow assessment as well as the mid flow and the inflow, and we can measure flow at every part of the cycle, which is pretty interesting. So. And there's a just a description of what we're talking about here. Um, I think that's all you need from that slide. We measure flow at zero point 0.5 seconds, 1 second, 2 seconds, and 3 seconds. But by far, the FEV1 is the most important number, and it's what we base our diagnosis on. There is a thing called the mid-flow, which is the FEF 2575. And the thing that's interesting about that, that's the middle of the curve. And the thing about that is that often in obstruction, it's the first one that shows a little decrease. So everything else might be within normal limits, but the mid-flow is actually a little bit decreased. That would be like some early asthma happening. Let's see here. Forced inspiratory flow, we really don't use that. And there's nothing on boards about it, so I'm moving right on past it. Yeah. So here we go. This shows a peak flow, peak expiratory flow, PEF, FEF, FEV, and the mid flow, the 2575. And I think that's about all you need. Just shows you that we can measure the flow at any point in the curve. And there are value, is value in those things, yeah. So spirometry is by far the number one test that we do, and it's often done pre and post bronchodilator. That means we do the test, give the patient a treatment, usually with albuterol, and then repeat the test. You do have to wait about 15 minutes to repeat the test so that the albuterol has actually worked. Then we say, did the FEV1 improve? That's that key number. If it improved by more than 12% and at least 200 milliliters, we say that is a response to the bronchodilator. And it's what we would call a reversible airway obstruction. So the patient does have post-bronchodilator improvement if they go up by 12%, 200 milliliters. That's an important one. Most PFT machines provide a good printed report. Height, age, height, ethnicity, gender, all those things are taken into account. There are differences among the ethnicities. For example, I would like you to think about an African American friend, someone you know. Generally, African Americans have longer legs than similar Hispanic or Caucasian or Oriental or anything else. They just have longer legs. But because they have longer legs, if they're the same height, then they will have a shorter thorax. So a 6 foot tall male African American and a 6 foot tall Caucasian, the Caucasian will have more lung capacity than the African American. And that turns out to statistically be predictable. It's not a huge difference, but it's a difference. And you need to take that into account because it would make patients seem abnormal when they're not. They're normal for their own ethnicity. Yeah. So, why do we do this testing? Well, severity of lung dysfunction, change in lung function over time. We have lots of patients that have to have a PFT done every 90 days. We're tracking them. progression in lung function following a treatment such as chemotherapy, environmental exposure. There are certain jobs that have to have a PFT every year. Lung impairment or disability, black lung disease would be an example of that. We do a lot of pulmonary function tests. I once had a contract at my hospital in Ohio to do the pulmonary function test for Honda of America, and there were 12,000 employees, all of whom needed a pulmonary function test on an annual basis. We kept a couple of people busy just doing that. Okay, here we go. Other types of PFTs include nitrogen washout, helium dilution, body plethysmography. Those three determine the residual volume that we've talked about several times. We also do diffusion capacity testing, and we do bronchial challenge testing. That's kind of an interesting thing. Let's say you think the patient has asthma, but their PFT is normal. We have them breathe methacholine. Let me just add that here because you definitely need that. Methacholine, or histamine. That's one you've heard of. We have them breathe that and see if we can make them go into bronchospasm. That seems cruel, but it's how we make the diagnosis of asthma. If they respond by having bronchospasm, they've got asthma. There's an exhaled nitric oxide test that we do as well, respiratory muscle tests, 6-minute walk tests, cardiopulmonary tests, sleep studies. All this stuff falls under the category of pulmonary function testing. So the PFT lab's a busy place. The problem for students trying to learn it is usually there are only just a few people in the department who do that testing. The rest are out on the floor or they're in the ICU. So, you just don't get a lot of experience with it, is what it comes down to. Nitrogen washout, we use pure oxygen to wash the nitrogen out of the patient's lungs, and we measure it. So that gets us the residual volume. That's nitrogen washout. Helium dilution is another one. I bet they're going to talk about that here. Well, not yet, because we're going to talk about closing volume. We can determine the closing volume, the volume at which the small airways begin to close in the lungs. And that can tell us about how bad the patient's asthma actually is, bronchospasm. There is a multiple breath nitrogen washout. I don't see anybody doing that. What we do these days is a single breath procedure. But we wash out all the nitrogen and measure it, and that gives us the residual volume. We can then calculate the functional residual capacity. That's the one I was asked about on my test, where we've got the expired volume, the percentage of nitrogen at the start, and the percentage of nitrogen at the end. And now you don't have to actually do that math. It's all done in the pulmonary function computer. When I started, we had to do the actual calculations ourselves. We had to measure the flow volume loop. Wow. Helium dilution is the next one. Helium dilution is where you have the patient breathe helium. They sure talk funny when you do this, but you have them breathe helium until it equilibrates. It dilutes in the residual volume. It takes about 7 minutes for that to happen. Now, in some emphysema patients, it takes quite a bit longer than that. But the helium concentration is usually about 10%, and by the end, it has come way down because it's diluted. And that tells us how much dilution determines how big the residual volume is. So it's a pretty, smart way of getting at the residual volume. And there's the formula for that. C1 times V1 equals C2 times V2. You won't have to actually do that calculation. Nobody's seen that on boards. But it's the initial concentration, the final concentration, and the volume, and the total gas volume. And that's just another way to look at that to get to the volume. You won't have to do that calculation. Never. All modern PFT equipment does that for you now. Body plethysmography is a fascinating test. affectionately call it the body box or the phone booth. It is a clear, uh, what would you call it? Transparent, yeah, box that the patient actually goes into. And I might mention once in a while there's a patient that's very claustrophobic and they cannot. They try and they just cannot stay in that box, even though they can see out, but they're so claustrophobic that they can't. We put the patient in there, we have them pant against resistance. We have them pant against resistance and measure their residual volume. So it is the most accurate way. Now, that is something that we've seen on boards, um, that which is the most accurate way for determining the residual volume, which gets you the FRC, and it is the body plethysmograph. And there we go. There's a picture of it right now. The patient's panting. That's that little line that you see there. That's the normal pattern. Asthma looks a little different. COPD looks a lot different, but they're all residual volumes. All right. Diffusion capacity. This is where we measure diffusion across the alveolar capillary membrane, and we actually use a very small amount of carbon monoxide. Yes, I said carbon monoxide, meaning the gas that can kill you if you get up to 20 parts per million, but we're using such a tiny amount that the patient is not harmed. Um, and we just measure how quickly it diffuses across the alveolar capillary membrane. It is the single breath test these days that we do. They just take a big deep breath in, they breathe the mixture, which is 0.3%, very small amount, and we measure how much the patient diffuses over 10 seconds. We have them exhale completely, and whatever's left, we measure that, and we know their diffusion capacity. So let's say the patient has pulmonary fibrosis, very thick, scarred lungs, then they will diffuse less because of all that scarring. Let's say that they have emphysema, then there's a lot of damage to the alveoli, and they will diffuse less because of all that damage. There's just less surface area. Bronchial challenge is the one we mentioned here a little bit ago. The one that's used most commonly is methacholine, and I think that's the one that you would see at your hospitals. I'll be interested to find out once you've seen this done. But we try to make the patient go into bronchospasm. We always, if we do put them in bronchospasm, and a lot of times we do, there's histamine as an alternative, but we always give them an albuterol treatment afterward to bring them out of the bronchospasm. That's pretty important. All right. It takes a 20% improvement. If there's a 20% improvement, we say that patient does have asthma. Exhaled nitric oxide, this is a useful test, relatively new test. And what it does is it tells us if inflammation is coming down or going up. If there's more exhaled nitric oxide, then it tells us that patient has more inflammation. But if it's coming down, if that number is getting lower, then our steroids are working. Eosinophilic airway inflammation, responsive to steroids, will bring that exhaled carbon dioxide down. All right. We also do some tests of the respiratory muscles, like the MIP, maximal inspiratory pressure, and MEP, and the minute volume. Yeah. We want to know how strong the respiratory muscles are. And let me give you a key number for that MIP. It needs to be at least minus 20 centimeters of water for the patient to breathe effectively on their own. If their MIP is less than minus 20, I can't get the zero to go in there. There we go. Then the patient will need to be ventilated. Yeah, it's serious business. Now, your MIP is probably a minus 90 or minus 100, healthy young people. But if the MIP goes below 20, the patient will need to be ventilated. If the MEP should be about, positive 80, 90, something like that. But if it's less than positive 40, centimeters of water, then the patient does not have an effective cough. They do not have an effective cough. So both numbers are pretty important. 6-minute walk test. How far can the patient walk in 6 minutes? It's amazing. When patients come to us for pulmonary rehab, sometimes they can only walk a very short distance, but that will improve with their pulmonary rehab. Yeah. I don't know how far you guys could walk in 6 minutes, but it's a long way. Healthy young people can walk a long way in 6 minutes. If patients can only walk 350 meters or less, then they are at much higher risk for not surviving. All right, I'm just checking to see how many slides left here. 64. So we'll get this one done right now and probably have to do the other one this afternoon. I'm doing this on Tuesday morning. Cardiopulmonary exercise testing is where we actually put the patient on a treadmill or exercise bike and then do a lot of the same tests that we would normally do at rest. So that's pretty interesting, and you may get involved in that cardiopulmonary exercise testing. Respiratory rate, oxygen consumption, CO2 production. We can measure all of that during exercise, and it will tell us a lot about the patient's fitness and just their general cardiopulmonary health. Normal oxygen consumption increases from a normal level of 250 to as much as 3,500 when somebody is really exercising hard, maybe as much as even 5,000. So think about your body's ability to do that. At rest, we only consume about 250. But if we're running from a bear, that's one of my professors always said, if you're running from a bear, you're probably going to get up to about 5,000. Increase in heart rate. The athlete's heart may be 40% larger than non-athletes, and it's not the thickness, it's dilated in a good way because the heart is pumping more each time. Each time it pumps in a well-trained athlete, it's pumping more. That's called the stroke volume. And this goes into a level of detail that you really don't need as a respiratory therapist. Sleep studies are fascinating. Polysomnograms. We're measuring a lot of different things, but let me give you some terms that definitely show up on boards here. There is a nasal thermistor at the patient's nose, which is measuring airflow. And that tells us, is there actual air moving in and out of the patient's lungs? There's also a thing called a strain gauge that is around the patient's chest, their lower chest, and that is measuring respiratory efforts. So what we sometimes see is that there are respiratory efforts going on, but no airflow going on. And that would be obstructive sleep apnea. Patient needs CPAP or, needs some kind of treatment for the obstructive sleep apnea. We're also looking at electrical activity by an EMG during that test. Also measuring the oxygen saturation, of course. But what we do sometimes is put the patient on CPAP. Once we see they're obstructed, we'll put them on CPAP and see if we can fix it. I think this is the smartest thing that's come along for a while. What we used to do is do a sleep study, see the obstruction, send it to the doctor. The doctor would say, okay, yeah, they're definitely obstructed, so let's do another sleep study with CPAP and see if that fixes it. Well, today, they trust the respiratory therapist to just see the obstruction ourselves, put the patient on CPAP, and see if it can help. And also, how much did it take to help? There's a board question. There's a board question that says you're doing a split night study. You have placed the patient on CPAP. You've set it to 5, but the patient is still snoring loudly. The patient is still snoring loudly. What should you do? Well, what you should do is turn up the CPAP. You want to increase it until you get rid of their obstruction, and part of the obstruction is the snoring. So there's also a thing called multiple sleep latency test, which is interesting. It's how quickly does the patient fall asleep If the patient falls asleep very quickly, they may actually be dealing with a narcolepsy type problem, something that needs to be addressed. Actually, very dangerous. Let's say with driving a car. Yeah. Maintenance of wakefulness test is another thing we do. Assess their level of daytime sleepiness. I have a student who actually had that test done, and we found out there was a significant problem. Now she's on CPAP and doing much, much better. Peak expiratory flow is the how much the patient can exhale with their fastest breath out, the flow rate, peak flow. This is very helpful for asthmatics. Asthmatics should have their own peak flow meter. They should have their own peak flow meter so that they can check this and see how it is from day to day. Peak flow measurement, that's the device right there. Patient should actually be holding it level. She's not doing it quite right. It needs to be level to do this correctly. But she blows as hard and fast as she can through the peak flow meter, and we measure it. Let me give you some numbers that will be showing up on boards. If the peak flow is less than 80% of the patient's personal best, less than 80% of the patient's personal best, they need to be seen. They need to go to clinic or at least have a telemed visit, something like that. If the peak flow is less than 50% of the patient's personal best, they need to go straight to the ER. And that honestly could save a human life, because if their peak flow is less than half of normal, they're in a full-blown asthma attack and are in trouble. So 80% and 50% are your key numbers there. Incentive spirometry is not really a test of function, but it's an exercise. What we do is about 10 breaths per hour, every 1 to 2 hours, 10 breaths with the incentive spirometer. It's just a little respiratory exercise device. And, it helps to keep the lungs open, avoids atelectasis, probably avoids post-op pneumonia, which used to be a huge problem. I'm a believer in incentive spirometry. I was hoping they might show us a picture of an incentive spirometer, but you're going to see it in lab here pretty quickly anyway. Complications, well, it's effort dependent. That's the thing you need to know. If you don't get the patient's best effort, then you do not have reliable results from the pulmonary function. One thing we got to be careful with is, we would like to stop the patient's medicines so that we see them kind of at their worst on the pulmonary function test. But we got to be careful, because once in a while, a patient, you stop their medicines and they wind up in the ER. So let's see, unstable chest wall, flailed chest, recent heart attack, pulmonary embolism, cerebral aneurysm, recent eye surgery. We wouldn't want to mess that up by having the patient blow hard. Recent surgery on the thorax or abdomen. We need to be a little careful about who gets these tests, but the great majority of patients can do a PFT without any harm. Yeah. Claustrophobia is a big issue with the body box. Some patients, it's not worth fighting. We've got other ways to do it. We've got other ways to do it. But if the patient is so claustrophobic they can't get in the body box and stay there, then we'll just do a nitrogen washout or a helium dilution. Obstructive disorders. This is the CBABE I mentioned the other day. They all fit into that category. Let's do that again, because that one is so helpful to students. It is cystic fibrosis, bronchitis, asthma, bronchiectasis, bronchiectasis, and emphysema. That is the CBABE obstructive disease list right there. This slide is also talking about those. But we're going to see that first and foremost in the FEV1 to FVC ratio. It's going to be less than 70. FE1 to FVC ratio, less than 70%. That tells you obstruction. And then we have to figure out which of those obstructive diseases. Yeah. This shows you the airflow limitation that's taking place in a patient with an obstructive problem and also a restrictive problem. Restriction is measured in a lower volume, but obstruction is measured in a scooped out pattern. I hope we're going to show you the flow volume loops also. If not, I'll have to go find those. Restrictive disorders, if it's not CBABE, it's restrictive. All the other diseases, interstitial lung disease, pneumothorax, ARDS, sarcoidosis, pulmonary fibrosis, which is so common in Western America. Oh my gosh, we have so much pulmonary fibrosis. And I know why that is. It's the dust that we all inhale. And some of us in our work. That's it. That perfect, perfect, perfect. The one that has the scooped out pattern is obstruction. The one that is smaller is restriction. And the red one, the more red one, they should have used a different color. Why would you use two different reds? But the larger red one is the normal broad mountain pattern. There you go. That's a very useful graphic right there. So PFTs, we do them every day. We use them to diagnose, to monitor treatment. They're really very, very useful. I don't know how we would do pulmonary medicine without them. I can't even imagine. Uh, we're going to use them to assess airway function, diagnose, monitor. Uh, Basic PFTs start with spirometry, but then include tests to get the FRC, which really means getting the RV that adds up to the FRC. And those three are nitrogen washout, helium dilution, and body plethysmography. We also do diffusion capacity, bronchial challenge, exhaled nitric oxide, and respiratory muscle testing. And 6-minute walk test and sleep studies, cardiopulmonary exercise testing. There's lots of testing to be done. And some folks do actually call it that at the hospital. Yeah. What do? I do the pulmonary testing. And, typically a hospital, good-sized hospital will have 3 or 4 people that focus on that. And they, really, become experts in that piece. So 6-minute walk, sleep studies, cardiopulmonary exercise. And I think that's everything you need on PFTs. We'll practice reading some PFTs together, and I think that will also help. I'll be back later today with the chapter on ABGs, which is also very important.